So thank you everyone for coming. This is the first time that we have done this. And so for those of you who do not know me, my name is Christian John Lillis. I'm the co-founder and executive director of the Peggy Lillis Foundation for C. diff Education and Advocacy. This is our first ever State of C. diff Town Hall. We very well might make it an annual event. Our goal for tonight is to share with all of you what we see as the state of C. diff across a range of sectors and communities, and as well as kind of have a discussion to the extent that that's enabled through Zoom. The first thing we need to start out off the gate is we do want to thank our friends at Pfizer for providing us with an unrestricted educational grant. Just so you guys know, Pfizer had no role in developing any of this content. This is totally ours and our presenters. But we want to be sure that we're being completely transparent. And so I'm also super lucky to be joined tonight by three incredible presenters who I admire very much and who I've learned a lot from, including Libby Dodds-Ashley, who is Director of Operations for the Duke Antimicrobial Stewardship Outreach Network at Duke University, Dr. Eric DeBerke, who's a professor of medicine and the clinical director for transplant infectious diseases at Washington University in St. Louis, and Malavika Tampi, who is the manager of the Center for Evidence-Based Dentistry at the American Dental Association. And again, I probably look better in that picture, but I am Christian John Lillis. And as you all heard, I did get out of Brooklyn College with a degree, but otherwise I went to the School of Hard Knocks. So I'm going to walk through how PLF sees things in terms of stats, treatment, innovations, and most importantly, the impact of C. diff on patients. Then I'm going to have a chat with our illustrious presenters, Libby Dodds and Eric DeBerke, and then Mal is going to finish at the sort of presentation portion of it by talking about the work that the American Dental Association has been doing to change the way dentists prescribe antibiotics, which is a huge amazing bit of work that they've been doing. And then I have a couple of questions that I'll pose to each of our, to all of our panelists to get their input. And then we're going to open up to questions from the audience. So once we do that, if you know to use the raise hand function, we could do that and have you unmute and ask your question, or you can just type it into the chat box. And if it's aimed at a particular presenter, because maybe not everything, you might have something that's about dentistry or something that's about the kind of antibiotic stewardship work that Libby does, you can certainly just put like for Libby, for Dr. DeBerke, for Christian, and then put your question. And Bernie, who is my amazing aide de camp, will keep her eye on that and make sure that we answer all of your questions. So for the uninitiated, if you don't know about Peggy Lillis Foundation, I just want to share a little bit more about who we are. So me and my brother Liam and our family and friends started Peggy Lillis Foundation following the death of my mother, Peggy, from a community-acquired C. diff infection in April of 2010. My mother was one of the best people I've ever known, and I've met a lot of people since she died, and she's still in my top 3. And so a big part of what inspires us is who she was as a person. They may come out a little bit through this, but we also have tons of other content that feature her very readily. A desire behind the town hall is that we continue her personal life mission of education. And then in terms of our own work, we are focused on combating C. diff through educating the public, including through things like this town hall, empowering advocates, people who either had C. diff or like us lost a loved one to C. diff, and ultimately shaping policy. So that's who we are. And so I wanted to start off with some basic statistics just to ground us. So I'm assuming all of you know that C. diff, or Clostridioides difficile, is a bacterium that causes diarrhea and inflammation of the colon. there's probably somewhere between 500,000 and 800,000 infections in the US annually. At least 29,000 Americans die from C. diff either as a direct cause or with it as a contributing factor. About 1 in 6 patients who get C. diff will get it again in the subsequent 2 to 8 weeks. 1 in 11 people over age 65 diagnosed with healthcare onset C. diff will die within 1 month. I personally feel like the current pandemic we're living through has sort of changed how we see infectious disease in a range of ways that I think will come up throughout this town hall. But I think that in some ways it feels like it's minimized some of the things that, you know, were considered such urgent threats prior to COVID. But I think it's more important than ever that we take a lesson from COVID and decide that, you know, any serious infectious disease that is killing tens of thousands of people needs to be addressed. And so that's a big part of what we're here to do. And so, you know, when it comes to statistics, one of the challenges that we'll talk a bit more as we go on through the presentation is that since C. diff is only reportable by certain kinds of institutions and is not mandated to be reported by every healthcare facility, it's likely that we have gaps in our knowledge, despite the incredibly good work of scientists and researchers. So despite our uncertainty, it does appear that we've made some progress, particularly where hospital-associated C. diff is concerned. So a study that came out in April of 2020, so right when COVID was capturing everyone's attention, showed that there was a decrease in C. diff infections, hospital-associated C. diff infections, from 476,000 to 462,000. But more importantly than that, in looking back over the data, researchers believe that the nucleic acid amplification testing, which was used a lot in the beginning of the 2010s, might have led to an overdiagnosis of C. diff in patients who were simply colonized. So based on that, they argue that the real decline in hospital-acquired C. diff may be as high as 36%. And they believe that the rise of antibiotic stewardship programs, which are now mandated for many healthcare facilities, is the likely cause of such a good decrease. However, there hasn't really been any change in community onset C. diff infections, and that accounts for about 50% of all cases. And also hospital mortality from C. diff did not change during this time. So I think the important thing of you know, there not being a change in community onset is that we have low, this particular infection is not well known. And so often people learn about it when they get diagnosed. And so, you know, if you're in the hospital, at least you're surrounded by people who will know quite a bit about C. diff. Whereas if you're in the community, you're hopefully, you know, Googling and coming across an organization like ours. So this is not exhaustive, but just to give a general sense of where we are in terms of treatment. So Shea and IDSA updated their guidelines in 2018. They determined that metronidazole is no longer recommended as a first-line therapy, but it is still prescribed. So it's important for patients to know what is considered best practice so they can advocate for themselves. Both oral vancomycin and fidaxomicin are now recommended as the first-line options. For those of you who are with us who are patients, you may have had somebody try to prescribe you fidaxomicin and struggled to get it because it's less often covered by insurance than vancomycin, and it's also on fewer hospital formularies than vancomycin is. So there has been some uptick in the use of fidaxomicin, but vancomycin is what most people get for their first incident. And then in 2016, basilitoximab, sorry, I can never say that, was approved as an adjunctive therapy along with an approved antibiotic because it binds C. diff toxin B. And something to note is that this drug was not included in the 2018 IDSAHA updated guidelines. So then the last thing, and this is something that many, many people on this call may have experienced with and has certainly captured the imagination of the media, which is fecal microbiota transplant or stool transplant. So right now, according to the guidelines, FMT is recommended for patients who experience 2 or more recurrences following standard antibiotic treatment. It is still considered experimental and has been widely available solely due to enforcement discretion by the FDA. Now, there was some recent news last week, which is that Open Biome, which was a sort of independent stool bank that was shipping a lot of these treatments across the country. Well, first, it has been unable to ship since COVID started because we lacked a good stool test for COVID. That has since come on the market and is available. But because it was so difficult for Open Biome to work over the past year or so, they have made an announcement that they're planning to begin to wind down their operations. And so what that means is that should Open Biome shutter before a new microbiome or a new therapy is approved, it will be much more difficult for patients to get an FMT. And that's something that PLF has been working on, but don't fret yet, because there are some new treatments on the way. And there are also medical centers that have their own stool banks. And so FMT will not be completely gone. Talk a little bit about the state of C. diff patients. So as I mentioned, only about 1/3 of Americans have heard of C. diff, so most people learn about it when they're diagnosed. Most patients do respond to standard therapy, meaning they get an antibiotic and, in a week to 10 days, they're back to feeling like themselves. But 20 to 30% of patients will suffer through 1 or more recurrences. We did a big educational push in November, and we got a lot of feedback from patients, a lot of new feedback from patients. And the thing that came through loud and clear was that most C. diff patients feel unseen and unheard by their doctors and the larger healthcare system. And a lot of them feel like C. diff isn't taken seriously by policymakers and by providers as it should be. And, I think if you're struggling with a disease for weeks or months and the treatment options are limited, it's very likely that you will feel that way. And in addition to the physical and economic impact of C. diff, people losing work, unable to go to the office, unable to work if they're paid hourly, many people who battle through multiple recurrences experience lasting mental and emotional challenges like agoraphobia, fears of contamination, and even PTSD. And then some people do struggle with what we kind of define as post-infectious IBS or gastrointestinal issues for months or years. So this is definitely a patient population that has a lot of unmet needs. Now, the good thing is that there has been a lot of innovation over the past 7 to 8 years. There are multiple microbiome-based therapies that are either currently enrolling or have recently completed clinical trials and are moving toward applying for FDA approval. So kind of spurned on by the success of FMT, companies have been developing a way to restore the gut microbiome in a way that is more standardized, more sort of developed in a lab and produced in a lab, and therefore we know exactly what's in it. So taking all the good parts of FMT and kind of leaving aside the parts of it that are less desirable. And at least 2 of those companies have finalized are done with their phase 3 trials, and they're sort of doing the data analysis and preparing to submit to the FDA. Now, COVID-19 is kind of the elephant in the room of this entire discussion, because the impact of COVID-19 has meant that trials have been slowed. It's been harder to enroll people. And also, of course, the FDA has been incredibly busy working on the approval of COVID-19 vaccines with, thankfully, great success. There's a couple of biotech companies out there that are also developing new narrow spectrum antibiotics. So they're looking at ones that harm the C. diff bacteria but leave the rest of your gut microbiome intact. And not lastly, but there's been some great research. You can find a really great blog post on our website, and I'll drop that in the link when I'm done talking. I'll drop that link in the chat when I'm done talking about research that increasingly supports the use of probiotics either as a preventative, like while you're taking antibiotics, or as an adjunctive to people who have had C. diff to prevent a recurrence. And the other thing is that preventatives, including a vaccine for C. diff, are also moving towards finalizing their clinical trials. So Pfizer is actually working on a vaccine, and it's unclear exactly when it will be available, again, because COVID has disrupted so much, but the preliminary data is supposedly very promising. So last two things I want to talk about before we bring Libby in here. When I talked about our mission, I talked about how we look to shape policy. And so for us, policy is very broad. So there has been, since 2010, since I first got involved in this work because of my mom, public policy for C. diff has improved. A lot of work was done under the Obama administration to deal with antibiotic resistance, antibiotic stewardship, and that had benefits for C. diff and other antibiotic-resistant infections. But currently, C. diff surveillance and reporting policies exclude nursing homes, children's hospitals, and there's no requirement for community cases to be counted or reported. The FDA continues enforcement discretion regarding fecal transplant. And as I mentioned earlier, fecal transplant has been really, really hard to get during COVID. So another thing that we have been thinking a lot about is that treatment guidelines, such as the ones that I was presenting on about earlier, they're largely developed without input from patients and caregivers. And we think that's something also that needs to change. So we are looking to see how patients can have more of a voice in that. But overall, the thing that I would like for folks to think about is that since the 1980s, we've had a huge disinvestment in public health, especially for infectious diseases. And that has led not only to a lot of healthcare-associated infections and increasing antimicrobial resistant infections, but that lack of investment has also set the stage for what we're living through now. I'd say the last big societal push against an infectious disease was for HIV, and we've made enormous strides in that regard. But countries like ours, post-industrial countries, we largely don't think about infectious disease as a problem. We think of it as something that happens, whether it's something that's happening in Africa or in the global south. But the whole time, annually, about 270,000 Americans die from sepsis. And they get sepsis from an infectious disease. So, it is a significant issue for us and for our health. So last but not least, I did want to share with all of you some of the goals that we have been developing around policy. We're a pretty small organization, but we're always punching above our weight class. And many of these are also things that we're supporting that are not necessarily our specific policy that we're introducing. Something we have introduced and that we would love for people to get involved with is to have the Centers for Disease Control designate C. diff as a nationally notifiable disease. If you're unfamiliar with that, what that basically means is that it would be incumbent upon anybody who has a positive lab result or diagnosis C. diff to report it to the state health department and to the Centers for Disease Control. And it would mean that we would have much, much more robust data. And it would make it possibly easier for us to kind of bring attention to the disease and also to have it be something that the government pays more attention to. Another big issue is that, and you've seen this throughout COVID, is the need to modernize our public health data infrastructure. We think that in the age of Instagram and smartphones, that we should all be able to look and see what's happening at our healthcare facilities. Like, why can't we just find out how good or bad they're doing in terms of infection? But also just to have a sense of like, if you see every day now, we like know how many cases of COVID, 7-day rolling average, all this stuff. I think it would be great if we had a similar sense of all of the potential deadly infectious diseases. The other thing we're looking to do is to have C. diff and other healthcare associated and, very importantly, antimicrobial resistant infections be reported on death certificates. So this is this is kind of like, it really depends on who fills out the death certificate. So my mother's death certificate doesn't say C. diff anywhere. The autopsy says C. diff, C. diff, C. diff, C. diff, but then other patients, theirs do. And so we really feel like if we're going to take seriously dealing with antimicrobial resistant infections, we need to first understand how many people are being impacted by them. We have a kind of scary number, but it could be even scarier but I think even more importantly is that having that kind of data would tell us like which one of these diseases is actually killing people as opposed to making people sick. I want to get Libby in here in a second, so I'll just quickly mention that there are 2 pieces of legislation that are aimed to increase the development of new antibiotics, the PASTOR Act and the DISARM Act. We support both of those. We want to fully fund the critical federal agencies and also restore and grow the Prevention and Public Health Fund. So these are all mechanisms to provide more funding for public health, which we think is critically important. And then we also want to ensure that patient and caregiver input gets into future guideline development and that patients and caregivers have a bigger voice overall in the sort of development and treatments and preventatives for C. diff. So with that, I am going to stop presenting. Thank you so much for listening to all of that. I think it's going to hopefully help us have a very robust conversation. But so I do want to welcome Libby Dodds-Ashley. As I mentioned, she is the Director of Operations for the Duke Antibiotic Stewardship Outreach Network. And so, Libby, the first thing that we would love to hear from you is what is DASON, as we call it?
Yeah, and I already saw some questions in the chat about what antimicrobial stewardship was. And if it's not a term you've heard before, you're not alone. I think my mother struggles to tell people what I do. But we are teams that are in most US hospitals now that try to drive the appropriate use of antibiotics. And that's a hard job. So we work closely with infection prevention teams. Lots of people know infection prevention teams because they try to drive down the incidence of infections, and they're often very involved in things like Lyme-related infections or unnecessary urinary tract infections, infections post-surgery. But unlike infection prevention, where the target is 0, including the hospital onset C. diff infections like Christian talked about, in antibiotic stewardship, we have to carefully juggle being sure those patients that Christian talked about with sepsis get antibiotics quickly that are broad, that they need to help them survive. But at the same time, we don't have a lot of unnecessary antibiotic use. And when the CDC has done surveys of this, they find that about half the time, the antibiotics that are being used are too broad or too long or not quite necessary in the form they're given. So maybe some antibiotic is needed, but a short course is needed. Or maybe they do have an infection, but they don't need the broadest of all antibiotics to treat that infection. Or maybe they're going to surgery and they're going to get an antibiotic to prevent an infection, very important, but it continues for days after the surgery happens, which is totally unnecessary. So that's what stewardship programs do, is we work with all areas of the hospital to try to right-size their antibiotic use. And DASON is a stewardship network. So we do outreach. So we're embedded in the infectious diseases division at Duke. So we have all the great expertise there of all of our physician colleagues who are experts in the field. And we go out to 34 community hospitals throughout 5 states in the Southeast. These are typically smaller hospitals. Our average bed size is about 150 beds per hospital. And these are places where they might not have an infectious diseases trained pharmacist. Some of them, only about 30% of them actually have access to an on-site infectious diseases physician. So we go in and try to help bring some of that expertise, drive some of that appropriate antibiotic use through education, consulting, bringing data to the group.
Yeah, and I think that's something that those of us who live in big cities don't appreciate. I was asked a couple of years ago to go and present at the Arkansas Rural Access Hospital annual meeting, and I learned a lot of how many communities are served by these small, what we would call tertiary, which is kind of a terrible name, this idea of like these hospitals that are like, small community hospitals that are just absolutely critical. And yeah, they can't afford the expertise of a big city hospital, but that's why what you guys are doing is so important. So when you talk about supporting this network of hospitals, can you give us a sense of what that looks like?
Yeah, so we go on site to these hospitals. We believe that if you want people to use antibiotics in a different way, you have to go and get to know them. You can't just give them advice from a distance. So we go in and we get to know all of the hospitals. And we don't run a single stewardship program for 35 hospitals. We run 35 stewardship programs. So we go in and we really listen to them about what their needs are. Local resistance patterns are very different. So Duke Hospital is right across the street from the Durham VA, and their resistance patterns are entirely different. You can't just assume that because you're in the same state or the same region, things are the same. So we go in and get to know the local resistance patterns, the local practices, what surgical procedures they can do, because they're not all the same. And then we help them come up with guidelines, and we talk to their physicians directly to really promote antibiotic use that is appropriate and right size. And we do that not only while they're in the hospital, but also when they're transitioning to outpatient. Because, we spend a lot of time focusing on inpatient antibiotic use. And we've done some research on this and found that a lot of times when people get ready to go home, just for that added assurance, maybe they've had 5 days of antibiotics in the hospital and they only need a total of 5 days to treat their infection, but they go home with 2 or 3 weeks just, to be safe. And so we work across the whole continuum of care to try to really get antibiotic use down to the minimal needed to treat the infection so that we don't cause harm from our antibiotics. It's real important to us.
Yeah, and that's actually kind of been a moving goalpost, right? Because as antibiotic stewardship programs have come online and there's more and more research on, duration of use, it used to be told like, oh, take every antibiotic we give you. And now it's like, well, maybe take them if you still feel sick. And there's definitely some controversy. Well, controversy is the wrong word because there's more of like, we're unpacking more and more of like what works and how long. And I think that, patients are used to hearing, well, we're going to give you these and take every one of them. And so there's a changing, expectation. Like people think, oh, I'm going to go home with still on antibiotics, and maybe they're not. So that's another like a communications issue that has to be addressed as well. So the next question is incredibly loaded, which is, how is 2020 different from previous years?
Yeah. I think one of the biggest changes for the DASON network is for many months, we were not allowed outside of Durham. So we had to stay here and learn how to do some of that stewardship a little bit more remotely. Fortunately, we could rely on the relationships we already had. But the real story in this, and I think it's important, is that, we hear the stories on the news of how COVID was affecting these large hospitals. I can't tell you how different but the same it was in our community hospitals. I call on a hospital that is a 60-bed hospital that on one day had 75 COVID patients. Let that sink in for a minute. These are small community hospitals, and the staff was part of the community, so also getting sick. And at the same time, I've been a pharmacist a long time. I've never seen data flying at us so furiously fast. This is when you hear we are learning to fly the airplane as we build it. I cannot stress that more. We went into COVID. So last March we had a viral illness, and everyone wanted to treat it like we did H1N1. And particularly relevant to C. diff is in H1N1, we had a lot of patients with secondary bacterial infections. They would get sick, come in super sick very fast, and need broad spectrum antibiotics in a lot of cases. And so that's what we did when we saw COVID patients. We brought them in and we gave them broad spectrum antibiotics for a whole host of reasons. We had nothing else to give. And we hadn't learned so much. Fortunately, we've learned in COVID that the majority of these patients don't actually have a secondary bacterial infection. It's really the virus that causes a lot of this and secondary inflammatory response that we're learning more and more about every day. But every experience tells us about 60% of these patients are coming in and getting broad spectrum antibiotics. So it's a huge time where we need stewardship. But our hospitals are overwhelmed. Like I said, the traditional stewardship activities have gone on the back bench or completely stopped at many of these community hospitals and many large academic medical centers. And I don't think what's getting quite so many headlines is there's many reasons for that. One is they're just so busy trying to figure out what to do with the new treatments, how to get the vaccine stored, how to get the vaccine in arms. But also these hospitals have seen a decrease in their traditional patient volumes, so they have less revenue. And I can't think of one of my community hospitals that hasn't had to furlough at least a pharmacist. So they have more work, crazy conditions, less staff, and that means in a lot of cases, stewardship has gone out the window.
Yeah, I mean, that kind of answered the other question I had for you, but I think something that's worth mentioning, and I didn't include this in the policy goals slide that I had because we're still thinking about this, and we definitely need thinking of people like you to help us sort of craft this particular part of our policy, which is that typically the way that the Centers for Medicare and Medicaid or federal government writ large has responded to poor performance around infection control and even stewardship is to penalize financially these hospitals. And I grew up very poor. I didn't give my mom's whole bio, but we were on welfare, for many years when I was a kid. And so, my perspective, and it's also probably why I became a fundraiser, is that I've never seen a condition made better by removing money from it. And so while I understand the intention to create accountability for facilities, I also feel like, particularly when it comes to these smaller hospitals, it's very wrong-headed. Because in many cases, they could be doing their best and they're still going to have a higher rate, right, than someplace that has a lot more resources. So I think that's important. We're trying to think of like what would be what's a non-penalty way to address these challenges, right? What's a way to say like the hospital is part of the community. We want a healthy hospital and a healthy community. How do we make that happen together? Instead of it being like the hospital is doing a bad job and the community is mad at the hospital, but you know what I'm saying? Like to just have it be more of a sense of like, we're all in this together. Because I think COVID showed us that we're all in this together, right?
Yeah, and it isn't perfect, but something that's really started to emerge is state health departments have started recognizing hospitals for their stewardship efforts, by giving them sort of an award. Here in North Carolina, we call it Star Partners, and it can be different levels. And it's a way, because to do stewardship well, it doesn't end at the hospital doors. It starts before you get there and it continues long after you leave. And it's especially true for the community, because often when we have patients who come in and get C. diff a week after they're in our hospital, they've had multiple courses of antibiotics before they got there for various conditions. So we really need the community and everyone on board. And if there's an award and there's recognition, it generates attention that isn't just negative, and it's, oh, that hospital, the numbers just came out. And it was sad to look at how many facilities lost a percentage of their reimbursement because of high rates of certain infections or other factors. And it's much easier when it's, oh, our community hospital was just recognized for antibiotic stewardship, and it can really drive a community discussion. And in our network in Dayson, we have a hospital, it's in Statesville, North Carolina, and they got the highest level of recognition in North Carolina for their stewardship program. And there was an article in the newspaper about it, and people talked about it in the community. That's what we need, is we need everyone talking about why it's good to use antibiotics appropriately and not saying, oh, why did they have too many infections? Or, oh, that hospital looked bad. That's not, I promise you, nobody gets up and goes to work at a hospital every day to try to do a bad job. Everybody wants to do better. And we have to make it the environment where everyone's working together on antibiotic use.
Well, thank you so much. So we're going to bring in Eric now, but you're going to hang around to answer questions from the audience in a bit. But thank you so much, Libby. Hi, Eric. Hi, Dr. DeBurkey. Thank you so much for being here with us tonight. So you are a professor of medicine at Washington University in St. Louis, and you run the Transplant Center's Infection Control.
Well, I'm the clinical director of our Transplant Infectious Diseases Service.
Thank you. I was having a hard time getting my mouth around that one. So you're somebody who has been doing research and treating C. diff for many, many years. And so the question I wanted to pose to you was, how has diagnosis and treatment changed during your career?
Yeah, I'd say there's been a lot of changes and for the better, fortunately. One of the, actually diagnosis, treatment and really frustrations with both of those when I was a resident, internal medicine resident, is kind of how I got interested in C. diff from a research standpoint. I was very frustrated in managing these patients. Everyone seemed to have their own secret sauce, and it just, it seemed like the approach was just doing more and more and more. And, one thing I noticed with the diagnostic literature is almost every single, at least back when I was in training back in the early 2000s, all studies of a diagnostic at that point didn't include any patient information. You just had a stool specimen, and you knew if it tested positive or negative based on a variety of different tests. And what we had available for managing patients were either something called the cytotoxicity cell assay, which remains actually our best test to detect C. diff toxins in stool, but it takes at least 1 to 2 days to have a test result once the stool specimen is collected. So really the time frame of events is usually the patient has diarrhea. A day later, the doctor's rounding, writes an order for the test, and then it takes another day or so to get that stool specimen collected. So by the time you get that stool specimen collected and tested with that cytotoxicity cell assay, it's 4 or 5 days later. On the other side, the other main tests available in the US were something called the toxin EIAs, but the toxin EIAs back then, most of them were different from what's available now. In most tests back in the early 2000s detected only toxin A of C. diff, and C. diff can produce disease by 2 toxins, both toxin A and toxin B. And there are strains out there that produce only toxin B, and those strains that produce only toxin B can cause the same spectrum of illness as C. diff strains that produce both toxins. So those toxin enzyme immunoassays back then would miss cases of C. diff for sure, because it was just not testing for one of the toxins. And sometimes that was the only toxin being produced. And as a result of some of these, issues with C. diff diagnostics or something, the standard was if you ordered a test for C. diff, it was C. diff times 3, meaning that if that first test was negative, you would automatically send off a second test and third test. And then it wasn't considered negative until all 3 were negative because of the concern for the low sensitivity. But the concern for the low sensitivity is just because you're missing one of the toxins. And eating the toxin is going to help you detect that toxin because you're never going to detect it. And so anyhow, fortunately though, in the last couple of decades, we've kind of gone first circle. So the initial concern is low sensitivity. So PCR-based diagnostics came to the forefront because they are very sensitive. But kind of the downside of the PCR diagnostics is also their sensitivity, in that there are many people out there, there's more people out there colonized with C. diff who have no symptoms from it than people who have C. diff infection. And those PCRs are much more likely to detect those people where they're colonized with it but not having problems from it than the toxin-based tests. And then but if you're positive with that PCR, you end up on C. diff treatment, which is an antibiotic which disrupts the microbiome. I've seen patients in my practice where I don't think they had C. diff initially, but then they end up getting C. diff treatment when they didn't need it, and then they end up getting real C. diff. But now in after the PCR-based diagnostics, more studies were done where they actually followed patients, saw what was going on with the patients, what were the medicines they were receiving, were they on a laxative, if they had a positive test, did they receive treatment or not? And then, so again, the pendulum swung back with the currently available toxin tests that detect both toxins A and toxin B. In the US right now, there are no longer any of those tests available, commercially available, that test only for toxin A. So all of them test for both toxins. And those are probably weighing the risks and benefits of the different tests, probably better than a PCR as a standalone test for diagnosis of C. diff infection. And we're seeing kind of the pendulum swing back now, going from C. diff ×3 to PCR back to toxin testing. But actually with better approaches to toxin testing, we're not doing that C. diff ×3. Again, with that C. diff ×3, you just get more positives, but that's because it's something called a false positive, and that you're repeating the test more and more, you're eventually going to have a positive test, even just because no test is 100%. So that's where we are with it from a diagnostic standpoint. I think it's gotten for the better. And in the last 5 years or so, I've really noticed a change in the approach to testing, and I think it's gotten better with going back to toxin testing and using that PCR if there's a concern with the negative toxin that someone really has C. diff, and then you get PCR as kind of the arbitrator there. And the treatment, again, that's really come a long way since I was back in training as well. We did not have an adequately designed, adequately powered C. diff treatment comparison published until 2011. So that's when the phase 3 trials of vancomycin versus fidaxomicin or difficid were published. And those were the very first studies that actually were properly done to determine, with what we considered the standard of care approach, to go to the FDA, to have an FDA approved product. That was the very first time for C. diff where one of those types of trials had been done, what we call a double-blinded randomized controlled trial. And then even before you run the trial, you figure out how many people you need in the trial to have a significant result where you could believe it's true. And then often the FDA makes you do 2 of them, and you need to have the results look the same. Just really say, yes, that looks like it's a real effect, and not just by some random chance. And so that was in 2011. And then, but prior to that, based on a lot of smaller studies that were not properly done, that were often not blinded. So again, the investigators knew who was getting metronidazole, they knew who was getting vancomycin, and metronidazole was pennies on the dollar compared to vancomycin. And in all these small studies that were not really, didn't have enough people to say what if one was really better than the other, or one was worse than the other, showed that there was no difference, which is actually what you would expect from these small studies, is that you would expect them to show no difference. And so metronidazole was the main C. diff treatment. Again, 20 years ago, for an initial episode of C. diff, probably about 80 to 90% of people were getting metronidazole or Flagyl as that initial C. diff treatment. But then in 2014, there was a study published, again, remains the only adequately designed and powered study where they included both vancomycin and metronidazole. It was actually for, the purpose of the trial wasn't to compare those 2 drugs. It was actually for a different agent called televimir, which actually failed.
Right.
Fortunately, they included arms with both vancomycin and metronidazole, which show that vancomycin is better than metronidazole. You're more likely to respond to that initial treatment course with vancomycin than you are if you receive metronidazole. Probably you're about 10% more likely. If you get vancomycin, there's a 90% chance within 10 days your diarrhea will have gone away. With metronidazole, it's down to 80%. From other smaller studies, we know before that for severe C. diff, when it's more, more significant, again, that difference in treatment is even bigger between the 2. And so that's what kind of drove the 2018 C. diff treatment guideline update, with the demotion of metronidazole to no longer being a first-line treatment choice for C. diff. But like you said, Christian, I still see it a fair amount being prescribed for an initial episode or two. Fortunately, I think we've had a much more rapid shift in prescribing practices after a guideline has come out with the 2018 update than really most any other guideline that's ever been published. Because usually it takes 5 to 10 years before you see major prescribing shifts with, based on a guideline. But with the demotion of metronidazole in the 2017-2018 guideline update, there was a pretty dramatic shift. Where now probably 50 to 80% of people are receiving vancomycin for that initial episode versus the flip, and that happened within less than a year that happened. And I think part of it is with people like Elizabeth, like Libby. I think it's really the pharmacist and that shift with a lot of the kind of the chatter on the pharmacy listservs and things like that really seem to get the word out there saying, because I remember our pharmacists coming to us, are like, uh-oh, what are we going to do? Metronidazole is no longer first line. It's like, well, we got to use vancomycin then. So that's been a big shift. And now, with fidaxomicin or difficid, the IDSA guidelines actually now are doing rapid updates for specific areas as new treatments or new data become available. And there should be a rapid treatment update coming out shortly. I was told late last year that it'll be hopefully first quarter of this year. But when it comes to guidelines being updated, that means probably second quarter. But difficid is going to be recommended over vancomycin. And, if you look at those phase 3 trials, I think that's appropriate. That for the initial cure of C. diff, there's no difference in cure. Again, about 90% of people are going to respond. But where you see the difference between difficid and vancomycin is the recurrence. And people who get difficid, only about 15% of them recur, 10 to 15% recur versus, 25 to 30% who get vancomycin. So that's going to come out. Bezotoximab that you mentioned or Zimplava, that's going to be in the updated treatment. And it's going to be recommended if someone has a risk factor for C. diff or recurrent C. diff, that you should go ahead and give the bezotoximab. And that includes people that are experiencing a first episode of C. diff who might otherwise be at increased risk for recurrent C. diff. And so it'll be interesting to see how this update, when it finally becomes available, changes practice. I'm hoping at very least, having fidaxomicin rated above vancomycin, that's usually where you start to see insurance companies kind of give in regards to their pricing tiers. And what's covered. It's hard for an insurance company to say, well, no, we're going to force you to take an inferior agent when we know there's another one out there that's better, just because of cost. So I'm hoping that we will see that barrier to patients getting access to fidaxomicin hopefully will go down when that quick update is finally released.
Yeah, thank you. That was very, that was pretty thorough. So I think you covered my next question, which is like, what do we think are the best practices? Because we talked a lot about the guidelines. So I don't believe that you yourself practice this, but like, where do you, and let me know if this is sort of outside of your ken, but like, so where do you see FMT fitting in here, or potentially like a microbiome-based therapy once we have those, which will hopefully be soon?
Actually, that's something that I forgot to mention. Like I said, planning for this a webinar today, I told Christian I could probably speak for hours, both on diagnosis and treatment. So I forgot to mention FMT because I got so wrapped up in everything else I was saying. So that's an interesting area, and again, that's an area where really in the last 10 years we've seen a rapid expansion. Though FMT was done for C. diff infection even before we knew C. diff caused it. It was described back in the 1950s, and it wasn't until the 1970s when C. diff was identified as the cause of antibiotic-associated colitis. So it's been around. I think the open biome question, there's of one, half dozen of the other. And, open biome really increased people's availability to receive FMT, which is good. And the open biome process of screening their donors was better than what a lot of practitioners that were doing it on their own was doing. So that's good. I think a downside of it is that it really brought to a crawl enrollment into treatment trials of other microbiome-based products. Why would someone risk receiving a placebo if they're enrolled in a trial that's essentially the same product versus getting open biome and you're getting it? So, and although the open biome screening was better than probably most individual practitioners that were doing it, it probably wasn't quite enough. It wasn't to the extent of these companies that are trying to have a microbiome-based therapeutic become available. And there were some right around when COVID came out, there were several infections transmitted through open biome products because they were not screening people frequently enough. But they changed that, and then COVID came around, and that kind of put all that to a halt. But on the plus side, like you mentioned, there's several companies that are trying to have FDA approved microbiome-based products. And I know several of those companies to get that final hurdle, they've done their phase 3 trials. This is seen, the FDA agreed that this is an unmet need. And so they're only required to have one of these big phase 3 trials versus the two that I mentioned. For other products that are not considered urgent needs, they have a higher threshold to prove that they're safe and effective than when there's a gap in treatments or diagnostics or what have you. So right now, several of these companies have open label treatment only trials that have actually fewer exclusion criteria than your more rigorous phase 3 trials. And so that's what the FDA is asking them to do, to get more safety data so that when they submit their application to have an approved product, they can use that. So I think, I would encourage practitioners to look into those types of trials and try to become a site for it. So you can make that available to your patients in the absence of having open biome, and maybe, I guess right now open biome still is going to, work through the product that they have, but you'll facilitate, you'll be more likely to have an FDA approved product when open biome no longer exists if you enroll patients into these trials whenever they're eligible.
Yeah, and I'm quite friendly with the people that run open biome, and so I got a phone call before the news broke, and for myself, fecal transplant, yes, it was available, but it was not. I feel like it really sort of caught fire in 2012 and 2013, where everybody started talking about it, and the press kind of found out about it, and they had this kind of like fury, and I don't know, like it's like, oh, we're going to talk about people getting poop transferred into them, and it's like, it becomes like BuzzFeed has a listicle about best ways to get poop transplanted into you. So it just kind of changed the dynamics, and so I think because my coming of age and coming out at a time when HIV was completely untreatable, like, to me, I always considered FMT to be an intermediary step between having to do this kind of like almost when we used to take like blood from my arm and transfuse it into somebody else, like, it's how do we get this to be sort of more rigorous. But of course, many people are afraid. I've gotten several emails. People are afraid, like, well, what if my C. diff comes back and open biome's gone? And I think hopefully this will create some urgency on the part of FDA, to move forward on one or more of these products, so that we don't end up, with some significant gap where there's not an approved treatment, and there's, an open biome is gone. There are still, in addition to the infections from open biome product, there was also an incident at Mass General where their own stool bank had sort of unusual form of E. coli that we don't typically test for was in there. So we have a guest star in the background there. So I want to turn it over to Mal, and then we'll have some questions for you when we come back. So as I mentioned at the beginning, this is Mal Tempe. She is a manager of the Center for Evidence-Based Medicine at the American Dental Association. So for those who aren't familiar, my mother's C. diff infection started with her being given clindamycin prophylactically following a root canal. So we were very, very interested in getting dentists to change their prescribing behavior. And so that's what Mal is going to walk us through now, is how that has changed. And I want to give a lot of credit to the American Dental Association. The last 2 years, you guys have really stepped up and joined the fight, and we're glad to have you with us.
Okay, well, hi everyone. My name is Malavika. I am a manager, as Christian said, at the American Dental Association Center for Evidence-Based Dentistry. And that's part of the ADA Science and Research Institute. And today I'm going to be talking to you about C. diff infections in dentistry. Just a few conflicts of interest I wanted to disclose. I'm employed by the ADA SRI, member of the grade working group, which is a methods group that develops systematic reviews and clinical practice guidelines. It informs the methodology to develop those two products. I'm a member of the International Association for Dental Research's EBD, or Evidence-Based Dentistry Network, Leadership Council, and I have no financial conflicts of interest to disclose. A few objectives related to my presentation today. I wanted to talk about concepts related to antibiotic stewardship and dentistry with the hope of reducing C. difficile infections. And some of the key points that hopefully you'll be able to take away today are how antibiotics are used in dentistry, what system level efforts are being implemented, and these include ADA efforts. What are the main takeaways of ADA policies, which we call clinical practice guidelines, and how can patients engage their dentists in being a good steward of antibiotics? And I know Christian did an amazing job covering all of the statistics related to C. difficile infection, so I won't get into it. But one of the main reasons that dentists and organized dentistry and the ADA got into promoting antibiotic stewardship is because of an increased awareness of the harms associated with antibiotic use. And this includes C. diff infections, amongst other undesirable consequences of antibiotic use, which are on the slide here. And I wanted to quickly cover some new research that was presented at ID Week by a colleague, Dr. Katie Suda, who was on our panel for our most recent guideline. And her and her team discovered that in a cohort of VA dentists who are treating dental patients, and the cohort had patients with C. diff infections, that amoxicillin was the most prescribed antibiotic amongst VA dentists, and then second was clindamycin, and then for the treatment of the CDI, metronidazole followed by oral vancomycin was the most prescribed antibiotics. And the takeaways from this new research that I found most interesting was that most of the patients with CDI in this cohort that were prescribed antibiotics did not meet ADA guidelines or AHA guidelines, which is the American Heart Association guidelines for antibiotic prophylaxis prior to dental visits. And clindamycin was more frequently prescribed in this cohort than published literature on antibiotic prescribing by dentists normally captures clindamycin prescribing. So there are multiple reasons for this, and I wanted to note that this cohort is a smaller cohort and more homogeneous cohort, so that could contribute to these figures as well. So it's not easily extrapolatable to the greater dental prescribing trends across the United States. But I found it interesting that based off of their research, that they concluded that a lot of the prescription for antibiotics did not meet ADA guidelines. So this again justifies some of the work we're doing at the ADA to ensure that dentists across the country and even in these specialized health systems are prescribing more along the guidelines that are published. In addition to ADA efforts, there are systems level efforts in dentistry There's a huge effort in collaboration with the CDC to contribute to the antimicrobial resistance challenge. Me and my colleagues have presented at the Presidential Advisory Council on this topic. We work with FDI, World Dental Federation, and as well as ASTDD has efforts in antibiotic stewardship as well. And just to quickly go through some stats on why we care so much about how dentists prescribe antibiotics is because 10% of antibiotic prescriptions are by dentists, as Christian mentioned. Huge proportion of antibiotic prescribing is by dentists, and 30 to 85% of these prescriptions are suboptimal and not indicated. And as of 2-3 years ago, there were 0 guidelines in the United States for the treatment of dental infections and associated pain and swelling. There were no guidelines to inform dental care. And so one of the main efforts that the ADA has undergone over the past 2 years is to develop this guideline, which was published end of 2019. I presented for Christian a couple months ago with Katie, Dr. Suda, on this topic as well. But I'll just quickly cover some of the main takeaways from this guideline, because essentially that is the major messaging that the ADA is putting out in regards to antibiotic stewardship. This slide quickly covers the map of dental prescribing of antibiotics, and of course, it can fall into preventing an infection, prophylactic use of antibiotics, or treatment of an infection. And the pulpal periapical indication was the main one that we've been working on over the past 2 to 3 years, simply because this is the bread and butter of dentistry. So this is the common tooth infection, tooth pain, people holding their cheek coming into not only dental offices, but EDs or urgent care facilities, because they don't have access to a dentist, or their pain is so severe, or pain is late at night and they can't access a dentist during those hours. So we see these patients not only in, again, dental offices, but all sorts of other settings. So, and in large proportions. So it was really important that we prioritize this guidance as part of our main antibiotic stewardship efforts. And quickly, I wanted to touch on one note that really, in terms of stewardship and dentistry, the ideal situation would be that all of these different conditions would have treatment guidelines associated with them. But we have to start somewhere, and so that's why we're focusing in on the main conditions that dentists treat. Now, some of the mindset shifts associated with antibiotic use for pulpal periapical conditions, again, the common toothache and tooth swelling or dental swelling, the number one mind shift that we wanted dentists to take away from this guideline was that antibiotics cannot ultimately cure your tooth infection at all times, and definitive dental care will cure your tooth infection. So actually going to the dentist and having them cut open your tooth and draining the tooth is actually much, much more effective at relieving the pain and swelling than the antibiotic will be. So that was our number one mindset shift. The second one was that pain can be well controlled with over-the-counter medications such as Motrin or Advil, and in combination with Tylenol. And again, moving patients and clinicians away from the idea that they need an antibiotic and pain medication for tooth pain. And that is actually a very common belief that the antibiotic will relieve all of their symptoms, and that in fact, patients believe that it's the most non-intrusive way to treat many dental conditions. But really what they're not understanding, and what clinicians aren't understanding, is that there are undesirable consequences associated with the use of those antibiotics that need to be taken into consideration as well. And our evidence-based guideline presents all of the numbers that inform these decisions as well. So I can provide the link to anyone who's interested. The third mindset shift was that I'm only going to prescribe absolutely when they're absolutely needed, prescribe antibiotics when they're absolutely needed. And this is moving away from the just-in-case approach to antibiotic prescribing, which is a huge way of prescribing in dentistry, because patients aren't seen that often, or patients are in a lot of pain and they're crying and upset. And understandably, it can be very distressing for the clinician as well to deny the antibiotic if asked to prescribe it. So the absolutely needed terminology hopefully has seeped into some minds, and we're hoping that that will ultimately help clinicians face challenges in communicating with patients when prescribing or making the decision to prescribe antibiotics. A few more slides on some of the takeaway antibiotic stewardship points that we made as part of our guideline as well. The first is that we prioritize first-line antibiotics and then second-line and so forth level antibiotics. And we, again, prioritize antibiotics that had less harms associated with them and were comparable in terms of the benefits provided. And we've provided algorithms and other tools for clinicians to make these decisions. Secondly, we encourage that dentists identify true penicillin allergies. 10% of the population reports a penicillin allergy, but less than 1% actually has one. And this affects the treatment decisions that are made because ultimately a dentist would prescribe the first line antibiotic if the patient in fact did not have a penicillin allergy. So it's important that clinicians are aware of true penicillin allergies to prevent the prescription of medications that have higher risks associated with them versus not. Thirdly, there's little evidence supporting the common belief that shortened course of antibiotics contributes to antimicrobial resistance. So that common, thing that our moms have told us, finish your course of antibiotics. There's very little evidence to support that. And so the WHO, in addition to our guideline, is recommending that we stop the that patients stop taking their antibiotic within 24 hours of the resolution of their symptoms, and that they do that or make that decision in consultation with their dental provider as well. Number 4, delayed prescribing should be implemented. This is a new concept in dentistry. And essentially what this means is that the patient is given a form that says, this is the reason why you're not getting an antibiotic right now. If you need to fill it, either call back or here's a prescription to fill in a day or so. So I know that Michigan has done a great job creating the state of Michigan's public health department, and some of my colleagues who have worked with on those efforts are on this call. And I'm sure if anyone's interested in what this means and how that's being implemented in Michigan, you can check out their resources. And going back to the evidence base behind this, patient satisfaction is actually very comparable when you're providing a delayed prescription. So in dentistry, often, you want in any medical specialty or field, you want your patients to walk away happy. So patients actually find a delayed prescription acceptable as a way to proceed with treating their dental pain and swelling. And finally, shared decision-making is a fantastic idea when appropriately done and for the right clinical situation. And communicating with patients and allowing them to come to providers with with any questions that they have and any concerns really helps antibiotic stewardship efforts, because then they're not taking medications that they shouldn't take acquired from different places, such as friends or family, or prescribed to them at other times for other medical conditions or issues. And can dental patients be stewards of antibiotics? Yes, they absolutely can. I think there are obviously a lot of limitations to understanding some of the concepts related to antibiotic stewardship, simply because people are coming in with different rates of literacy, and I think it's really important that clinicians be prepared to have those conversations, depending with whomever they're treating, no matter what the level is that they need to explain these concepts. And also, some patients are really, really well informed and have great questions. So being able to make the time for patients to vet their concerns before an antibiotic prescription is provided. Patients are instructed based off of our for the patient pages to use antibiotics only when needed, to talk with a provider if you suspect that you do have a penicillin allergy so that testing can happen, not using medications provided for other medical issues, like I said, disposing of unused antibiotics appropriately, and knowing that most importantly, knowing that there are side effects to using antibiotics. It's not a no-risk pill that you just pop and feel better. There actually can be devastating side effects associated with the use of antibiotics, like C. difficile infection and antibiotic-resistant infections. I wanted to plug an upcoming collaboration between the ADA and the American College of Emergency Physicians. Like I said, a lot of these patients, dental patients, are being seen in EDs and urgent care settings because they don't have access to a dental provider or consistent dental provider. So the ASAP group actually endorsed our guideline, and we're working with them to write up a separate publication that will help medical providers treat these patients in a way that's antibiotic stewardship friendly. And one last note, when we were developing our guidance at the ADA for COVID-19 and reducing transmission risk for dental providers and their teams, it was really important that we acknowledged the recommendations in our antibiotic guideline and some of these mindset shifts, because we didn't want to start a new public health crisis in the midst of resolving another. So we didn't want antibiotics to be prescribed in lieu of seeing the dentist and getting the treatment that they needed to feel better, because we knew that there was risks associated with the antibiotic use. And so that was an entire conversation early COVID 2020. And it was really useful to have the evidence-based guidelines and the data available to help policymakers at the ADA make those decisions. So I'm really happy that we were able to work collaboratively with so many different people to help antibiotic stewardship efforts across dentistry. In summary, systems-wide and ADA efforts are in progress. It's really difficult for us specifically at the ADA to understand how our policies really impact quantitatively, impact prescribing. So if anyone knows of any research in this area, would love to connect or hear about it. Katie Suda, Dr. Suda, does a fantastic job on antibiotic prescribing and just prescribing in dentistry. So her research is always a great place to go if you have any questions. Priorities of antibiotic stewardship in dentistry include not only detailing appropriate and inappropriate uses of antibiotics, but helping clinicians and patients make these shifts. And that includes shared decision-making, patient engagement, as Christian mentioned, including patients in our guideline panels and during decision-making processes for policies, as well as interprofessional collaboration. Thank you very much.
Thank you, Malvika. So we're running a little over, and we did get a ton of questions. So I'm going to see if we can address those questions. So there was a question about if a patient's allergic to penicillin, why do they go to clindamycin instead of doxycycline? And I don't know the answer to that. Mal, do you have a sense?
I don't. These are the recommendations provided by our clinical experts. And so for me to say anything between doxy and clindamycin, I wouldn't be, I'm not, it could.
Talking out of turn.
Yeah, it just wouldn't be something I could really provide too much insight on, other than the fact that they believe that this type of antibiotic is more effective at treating the infection that's at hand while minimizing the risks. So that's all I can really say about that.
All right, so there's a question for me here that says, even beyond the patient perspective on guidelines, have an increase in their voice in FDA clinical trial endpoints. So what I would say to that is that we are, as we are looking at several potential new therapies and a vaccine and several other things, PLF is looking very closely at how we can increase the sort of patient perspective, patient influence into FDA around these issues. Endpoints could be an interesting one, but I think there's a lot. I think we'd have to sort of ramp our people up to get ready, because endpoints is a kind of very specific question that is sort of specific to clinical trials. But it's definitely worth considering. I think this there's a question about is anything being done about transitions of care, for example, discharge from hospital to nursing home? I don't know, Eric or Libby, if you want to field that one.
I mean, there are things being done. So, the CDC, what had traditionally been the hospital infection reporting program, the what's called NHSN, the National Healthcare Safety Network, where hospitals do report their C. diff rates, as well as central line infections, urinary tract infections, surgical site infections. So a couple of years back, the CDC did open that up also to nursing homes. Though that I don't work primarily in nursing home, I actually don't know what levers are in place. So CMS, Medicare, certain Center for Medicare and Medicaid Services, did say for hospitals to receive payments from CMS, they had to report their data to NHSN. That was the lever. NHSN is actually considered a voluntary reporting system. And so it's voluntary if you don't want to get paid for all your Medicare patients. So that was the lever to get hospitals to do it. And I think they've done the same for nursing homes, but I'm not exactly sure. But my understanding is that many nursing homes, if not the majority of them, are reporting their infection rates through NHSN right now.
Yeah, Eric, I can add a little bit to that. It's a little bit of a bigger pull just because the nursing homes don't have the same data coordinators, but this has actually been, if you want to look at a positive side to COVID, they got some rapid resources. So only during COVID actually have most of our nursing homes been able to flip the switch on NHSN, which means this is a great resource for us going forward to be able to track these infections better than we have been historically. So we try to look for the bright sides where we can.
So here's another question. Have CDI cases gone down during the COVID pandemic?
So, I mean, I'll go ahead and field that one first. There really are not much data out there at this point. But what I'm aware of, just both locally with my own experience, within our healthcare network, which is not as big as the DICON, nowhere near as big as that, but within our network, and also in talking to other people, it's almost kind of a push. As Libby mentioned, with COVID, a lot of these people get antibiotics, they're in the ICU for a long period of time, they're very sick. And so those are all important risk factors for C. diff. But on the flip side, they've got COVID, so everyone is really good at wearing their gowns and gloves. And so early on in the pandemic, when things really shut down, including pretty much any elective service within a hospital, and our active census actually went down, the number of cases went way down as well, but that was just a matter of number of people, but our rate stayed about the same. So the number of cases per number of people in the hospital stayed about the same, and it stayed pretty stable since then. And again, we do, people with COVID, there's evidence at this point that we are seeing more bloodstream infections in them. We are seeing more urinary tract infections in them, but that's just, they're very sick. They have a catheter in them for a very long time, either into the blood or in the urinary tract, and you have to flip them around for the ventilation. So we know that they're getting those other infections, but we're not seeing quite as much an increase in C. diff. And again, I think that's because all these other infections, you got this device coming in, and there's always skin on the bacteria or along the urinary tract. And when you flip these people around, it causes yanks and tears and hard to keep sterile. And so will increase the risk for those infections. But because and they're getting antibiotics for those, but since everyone's wearing their gowns and gloves, when they're seeing these patients, we're not bringing C. diff into the room. And so we're not seeing the increases in C. diff, but we are seeing, with those other infections increases.
I think partially, even in sort of community onset, it might be that with so many of the sort of elective or even outpatient surgeries being put on hold for many months, that people just weren't going home with antibiotics, and they're, so they weren't exposed to the healthcare facilities. So there may very well be a dip. But I think what people should understand is that the data that gets collected and reported at the national level is often 18 months behind. So we won't really know what the impact was for a few months, because they validate the data, they make sure that it's as accurate as possible. So the question, do people have thoughts on prevention of first occurrence of C. diff with proven probiotics? Would primary prevention not also prevent by default a recurrence?
Commercially available probiotics right now, in the best done studies, have not really shown benefit for preventing C. diff infection. Again, many of those probiotic studies early on kind of suffered like those other C. diff treatment studies, in that there really weren't enough people in there. And in some of those studies that have shown benefit, there's kind of some funny things going on in a lot of them. So it's hard for me to really put a lot of faith into them. Oftentimes the C. diff incidence in the population being studied, and those on the on the placebo, are really like not just 5, but 10, if not 20 times higher than what you would otherwise expect. So it's just something that doesn't really make me want to, if I was a betting man, I would not put a bet based on those data. But the larger, well-done studies that do have an adequate number of people to better assess it really have not shown benefit. So, we don't have a good primary prophylaxis at this point. And that ultimately might be related, there are medications being studied to prevent antibiotic-induced microbiome disruption. So that those might be products. There might be other products, so Dale Girding is studying his non-toxigenic C. diff, because if you become colonized with a strain of C. diff that doesn't produce toxin, it protects against colonization against those strains that do produce toxins. And so he's hoping to study that as primary prevention. They've had some early studies showing benefit at preventing recurrences, and they're going to do those follow-up studies. He finally found an industry partner to go to that next step, that phase 3 trial. But I know he's also interested in that primary prevention as well.
So we have a general question, which is, can you explain a patient being colonized with C. diff who would not have toxins being produced by the bacteria? I think this is something that's just more the basics of like the biology of C. diff, for lack of a better term, or the microbiology.
Yeah, I mean, C. diff is actually a bacteria that's everywhere around us. If you look at healthy adults without antibiotics, without diarrhea, about 3% of them, you could detect C. diff in their stool. But if you follow them over time, the 3% remains constant, but who has it changes. So, C. diff is, you're more likely today, with hospitals so focused on preventing C. diff and cleaning the environment, you're actually more likely to find C. diff in the home of an otherwise healthy person than you are in a hospital room, even a room that just had a C. diff patient. And so like Christian said, that's the normal biology of C. diff. The abnormal biology happens with the antibiotics disrupting the microbiome. And not only that, you probably have to have some issue related to that person's immune system not recognizing the C. diff toxins. And we've got very good evidence that having antibodies against toxins is important, related to the bezotoximab or Zimplava data, because what that is an antibody against that toxin B. And we know that can prevent recurrences. And so there's probably, the first thing is, what is that difference in the microbiome? Why do some people go on to develop C. diff infection versus not? Part of it is things we don't completely understand with the microbiome. And the other part is the immune system.
I mean, I always say that a lot of people, when they're struggling with the fact that they're sick or that they've had a loved one who's been taken from them by this, they want to know where they got it. And what I've encouraged people to think about is that we don't know. I don't know where my mother picked it up. I could speculate. We don't know. And so I think we should focus on what are the things we can control. And so something that we can control is the unnecessary use of antibiotics, is people being educated about C. diff when they're given antibiotics so they get treatment quickly if they do get it. So I think we have to focus on, the realm of what sort of the patient, clinician, health systems can control, because we find C. diff in dirt and feces from animals, like it's kind of all around us. So I want to be sensitive to that. We're just a couple minutes over, but there's a couple of questions that more or less boil down to like, how do we do more community education? Like, what do we think that looks like? Like, is Duke doing anything with its and DASON partners to help them sort of educate their patient population or their community about antibiotic overuse in C. diff? Or is there any way to do that sort of more broadly in the community? That's me mashing together a bunch of questions.
Yeah, that's a great question. There are lots of things going on. So one is we all participate in Antibiotic Awareness Week every year, and we encourage our hospitals and help them do a public outreach campaign as part of it. Just talking about it, I think, is so important. And what we're really trying to get a lot of momentum behind are things like antibiotic take-back days. I will confess that if you go to where my parents are currently located in Florida, they almost barter in antibiotics. Oh, I got a few Z-Packs, I got this, And so giving them a safe place to take their antibiotics to get rid of them when they're done is something that's really important. People are worried about the environment and exposing the environment to antibiotics unnecessarily, but working with pharmacy partners and the DEA on places where we can take these antibiotics to safely dispose of them when people are done. It's not good to have antibiotics sitting around. It's so tempting to have them. I think that is one big thing we can do. And it ties nicely, similar to a lot of the opioid stewardship efforts that are out there to try to take those drugs back. And then just in general, talking to patients, the overall assumption in the medical community and in the community outside of the medical community is that antibiotics are just so safe. And I think when you talk to people about them and you say, they can cause diarrhea that can kill you, people really don't have an appreciation for that. So including that when we discuss patients, this is why I'm not giving you an antibiotic today, because I will do anything that I think will help you. And I think that these antibiotics today have more of a chance to harm you. And I think helping also get our providers some of those tools they need to talk through these things are so important. So, really working to just make it, we have to weave appropriate antibiotic use into the fabric of medical care in a way that we're having to undo decades of thinking otherwise. So it's really just making it part of our everyday conversation.
Eric or Mal, do you have anything to add?
That summed up anything I would have said better than I would have said it. So, yeah.
Well, yeah, I think, I think it is a big challenge, and part of it is just more, I think public health messaging is needed as well. Not just, to the physicians, but can there be programs that gets that information directly to the consumer? I think that'll be an important aspect to truly helping everyone understand, and it could be C. diff specific, or it could be broader related to antibiotic safety. The only antibiotic class that's associated with more deaths due to adverse events of antibiotics is cancer chemotherapy, where that's actually a known risk factor. But most people don't recognize that there is that risk with antibiotics, and that's not just from C. diff either. There's other potential life-threatening reactions people can have. But I agree, unfortunately, that's not my area of expertise and how to educate the public. And that's part of the reason why I'm doing this and why I decided to become a member of the scientific, advisory committee of the Peggy Lillis Foundation is to help me better understand some of how this works and to help get the message out there.
Yeah, so what I would add to that is that so my grandparents, and to some extent my mother's generation, so like baby boomers and older, are very passive recipients of healthcare. And I think that Generation X and younger are becoming much more active, I hate the word consumer, but active in sort of their health and their healthcare. And I think that that's an important thing for us to all consider. So I'll give you a very clear example. My husband had a tooth extraction and preparation for an implant done last week. And so that morning he said to me, because I was going to an oral surgeon, not a normal doctor who knows all about me and all about my mother. But he said to me, he goes, well, how do I talk to the doctor about antibiotics? Like, you know, if they want to give them to me. And I said, well, I would open with my mother-in-law died from C. diff. And you're concerned about whether or not you need antibiotics following this procedure, and what do they think you need them or not? And then, you know, be prepared to ask if it's prophylaxis or if it's because they find an infection. So, you know, there's a big part of us that needs to kind of inform ourselves. And unfortunately in the US, we don't have great health literacy. But the other thing is that there are many people, too many to name, you know, both Eric and Libby are on our scientific advisory council. Mal has just been completely awesome, along with Dr. Suda, in terms of helping us with the dental side of things. But we have many, many of our patient advocates on this call tonight, and each one of them is doing the work of educating the public where they live. You know, I do liken it almost to coming out, you know, around sexuality. It's like a lot of people have a shame and a stigma because the primary symptom of C. diff is diarrhea. And people don't want to talk about diarrhea or the bowel movements and, you know, and that kind of stuff. And so, you know, we have to kind of overcome that taboo and have more frank conversations and share what has happened to us. And I think, you know, just getting more comfortable having those conversations and sharing, you know, your experience is a really powerful way to do that. And I do think that, you know, we need to put more efforts into getting both the federal and state governments to do more education around this stuff. Because, I mean, I remember like the you know, the HIV prevention campaigns, like you couldn't get away from them when I was younger, and we haven't seen something similar around AMR, antimicrobial resistant infections, or C. diff. So that's a big part of it. I do think we're gonna have to leave it there. So what I do wanna mention is that we have upcoming on April 20th and 22nd, our 2021 virtual C. diff advocacy summit. And so we hope you guys can all join us. It is for free. We will have many more presentations like this one, delving into all different kinds of areas of treatment, policy, grassroots organizing. And for those of you who are clinicians or nurses or doctors or scientists or even patients yourselves, we have a current call for topics. Where you can go to this little tiny URL, and I'm going to drop it into the chat as well. And, you know, it's a very short form. We just want to know kind of what you're planning to do and what you'd like to present on. And we would love to have as many of you involved as possible. We had about 300 people at join the event last year. And so, you know, we really would love to get more people involved. I do want to thank again Dr. Eric DeBerkey, Libby Dodds-Ashley, Malavika Tampi. You guys were awesome. Thank you so much for sharing your Monday night with us to help educate people on this. I also want to thank our scientific advisory council in general, who really, really helped me understand stuff. And I want to give a shout out to Bernie Deas, who's been helping us administrate this tonight. And again, a thank you to Pfizer for sponsoring it. We really, really do appreciate your time and your effort, and we thank all of you for joining us. And with that, I think we will say good night. And I hope if you haven't had dinner yet, like I haven't, you're going to have something delicious. And please stay involved. And we hope, you know, to have you be part of our movement to end C. diff. Thank you guys so very, very much.